Hey everybody, it's Dr. Eric Balcavage and Dr. Erica Riggleman. We're back for another edition of Thyroid Answers podcast. Good morning,
Good
Doctor.
morning.
How are you today?
I'm doing great.
So we are going to have a little discussion today about autoimmunity, kind of talk about what the different types of autoimmunity in the thyroid world are, and get into maybe some of the triggers and some of the things that may happen, and maybe differentiating what causes different aspects of thyroid autoimmunity, and just give you a little bit better insight into that. So you've got experience with dealing with patients with both Graves and Hashimoto's. I do as well. So we'll kind of talk about some of those things.
Yeah, I think this is a really important topic to understand because a lot of people have autoimmunity and they may not even know it because maybe they're not getting tested for it. But it's very common among a lot of the patients that come in. Yes, they have thyroid dysfunction, but they may also have some autoimmunity. And if they don't already have it, there's a likelihood that down the road they could develop some autoimmunity towards the thyroid, depending on what path they take. And so I think it's important because the traditional medical route tends to downplay the thyroid autoimmunity. There really isn't enough. When you have it, it's kind of just like, yeah, you have it. All right. Well, move on. That's it. They don't really give you an option and tell you that's a big deal. And I always see autoimmunity. It's that people, they don't just usually present with one. There's usually multiple autoimmune diseases that people are having. And it starts with one, but if you don't look at what's triggering the immune system to begin with, you could always develop, whether the next one is lupus or even something progressive such as MS or Parkinson's, down the road. So you always want to keep that in the back of your mind that if you are having autoimmunity issues that, it's likely you could develop one down the road if you don't really, get the immune system under control.
Yeah. And we talk about autoimmunity. I think the important thing to discuss is that there's got to be a couple components, right? There's usually a genetic component there. So you have underneath it, you may have a predisposition to develop autoimmunity. You talk about your HLA phenotype. Definitely women have a more likelihood of developing, and we think it has something to do with the impact of estrogen on the immune system. And then there's a trigger, something triggers it, right? So there's some type of a triggering event, genetics, and even maybe hormonal component to what's going on. So that's something to keep in mind. So when we talk about the thyroid gland, we've talked about this in the past, that the autoimmunity can either start in the gland or from a perspective of looking at things from a cellular perspective, that you can have peripheral tissue damage and you can have the release of things that like PAMPs, DAMPs. When we talk about PAMPs, we're talking about pathogen-associated molecules like lipopolysaccharides or some of the coatings of the organisms that can be kind of sent out from damaged cells or sick cells, and that signals the immune system. DAMPs are DNA-associated molecular pieces, fragments of DNA that can make it out into the bloodstream to stimulate the immune system to say, hey, there's a problem here. And then that can activate the immune system and start that process potentially of autoimmunity. We talked about in the past that the thyroid gland can detect those PAMPs and DAMPs as well. They've got toll-like receptors on them, so they can sense some of those things, and that can initiate attack or damage in the thyroid gland with or without an active local infection. But infection of the thyroid tissue by viruses or bacteria or a toxin could still initiate that same danger response in the thyroid gland and initiate self-damage, even without the immune system coming in. The thyroid tissues themselves can do essentially self-destruct. So there are a number of factors that can trigger autoimmunity, and it can be triggered from outside the thyroid gland or be triggered from inside the thyroid gland. Mm-hmm. So let's talk about some of the things maybe that might cause something to trigger an autoimmune response.
I mean, trigger an autoimmune response, I think that the first thing that comes to my mind is going to be food related things. I mean, 80% of your immune system resides in the digestive tract. Studies suggest that most autoimmune disease begins in the gut, whether that's pathogens, foods, there's something that, is initiating that immune response in the gut. So I think that there's a lot of food-based triggers. I think that especially with Hashimoto's or even, other autoimmune things that go along with the thyroid, I think that gluten and dairy are probably two big key components that, I mean, there's suggested molecular mimicry to gluten and dairy, that looks very similar to thyroid, components, that if you already have the immune system flagged towards those, that when it senses the gluten or the dairy and we have leaky gut, getting that into the bloodstream can almost, it thinks that it's, it sees it as thyroid and it already has the antibodies to it. It can create more of an immune response that can then, go down that thyroid pathway.
So let's kind of discuss that molecular mimicry thing, because people may not really understand what that is. So when we talk about molecular mimicry, what we're essentially saying is that the immune system sees, looks at this piece of the thing that's stimulating the immune system. We call it an antigen. And the immune system says, hey, this antigen is the problem. And so the immune system mounts defense to go get whatever that antigen is. And it produces typically things like antibodies that go after it, right? That's humoral mediated. But think of, for the listeners, one of the things to think about is, think of if somebody robbed the store and they were wearing a black hoodie, right? Somebody may give a description like the person robbed the store was wearing a black hoodie. The police would come and so they don't have a great description. So they're just they're pulling over anybody with the black hoodie, right? And so that would be more the molecular mimicry. The immune system is looking at something and saying that thing looks pretty similar to what they told me is creating the problem. And so the immune system attacks anything that looks similar to it. Does that make sense to you?
Mm-hmm. Yeah, no, I think that's a great way to describe it.
So
I always say that it's like having a wanted poster that the immune system is going around looking for it. And again, it can be very vague. And if it thinks it looks like it, it's going to go after it and at least try to, gather it up and have some sort of response to it.
Right. So what we need initially is some type of trigger. So that trigger could be a toxin, it could be an organism, it could be emotional stress, it could be foodborne, a protein, something triggers the cell damage or activates the immune system that triggers the immune response. And many of those things, it really just needs to be something that triggers a danger signal in our cellular system. And so we talked before about how disrupted sleep can create a danger signal. If you're constantly not getting enough sleep, that can create tissue damage, and that could potentially trigger it. Things like hypoxia, poor breathing, not getting enough oxygen to the tissues can create tissue damage. It can trigger those danger signals, and that could potentially do it. If you have a bacteria in the cells or tissues, that could trigger damage that initiates it. If you have toxicity, whether it's chemicals from your food, from your water, from the environment, from medications, something triggers that danger response, and that can trigger the immunity or the autoimmune response.
Mm-hmm. And I usually don't think it's one thing. I think it's the perfect storm. And most people, people want to look for that one big thing, and it's usually not that one big thing. It's usually the combination, and over a period of time that stuff builds up, and then can create that perfect storm.
Yeah, I kind of explain it like a teeter-totter, like the old school teeter-totter you used to play on. Like if you have a little bit of we're all adapted to take some cell stress, right? I mean, the cells are able to do that. It's actually pretty good to have some regular stress on the system. That's why exercise is good. That's why challenging yourself, a little emotional stress is all good. All those stressors make us a little bit stronger, so we behave or react a little bit better the next time, right? So, you train, so you can go run a marathon. You don't just go run a marathon. You train, and that makes you stronger. So some stress is good, but if all the stress is real negative stress and it's unrelenting and it just keeps adding and piling on, then enough stress can overwhelm the system and we trigger that danger response. And so I agree with you. I have a bad diet. I don't sleep well. I don't breathe well. I smoke. I got emotional stress. And it's just the accumulation of stress signals and danger signals eventually activates what we call that cell danger response. You get the tissue damage, you get this inflammatory immune activation, and the cascade occurs. So sometimes it does happen after single events, maybe, right? But I think, we see sometimes, especially women post-pregnancy, they'll have an activation of the immune system, and we can say, well, it's just the shift in the chemistry as you go through pregnancy and postpartum. Some women don't kind of flip that switch back, and it can trigger the autoimmune process. But again, I agree with what you're saying. If it was just that, why wouldn't every woman have the same issue, right? So there's probably some underlying things, genetic predisposition, other stressors, and that shift. They're just
there's a physical trauma too that happens with a birth too. So you've got the emotional stress, the physical stress, the hormonal stress. So again, there's just so many components to it.
Yeah, and I think it kind of, the correlation there would be menopause, right? So, some women fly through menopause no problem at all, but that's probably because their chemistry was really pretty healthy and their overall stress load wasn't too bad, and they could deal with the drop off of estrogen. For other women, they're already struggling. Then they have the drop off of estrogen, and that's enough of a switch where they have all this negative symptomatology. Their adrenals are already stressed out and not working well. So we see maybe a correlation there. So when there's that shift, it's probably not just the pregnancy that's creating the issue, but the other things that kind of the person was predisposed to that probably allowed them to occur. So when we're talking about autoimmunity, right, we can have two forms of autoimmunity. So we can have what we call Graves disease, right? And we can have what we call Hashimoto's autoimmunity, right?
Mm-hmm.
So it's important that you can have damage to the thyroid gland, and it can be a hyperthyroid reaction, which is typically what we call Graves. And that's an autoimmune attack against the gland, and it's hyperthyroid. And you can have an autoimmune attack against the gland that we associate with hypothyroidism, which is Hashimoto's, right?
Mm-hmm.
And so the issue is, how do they present when we see these things, right? So you want to talk about maybe either Hashimoto's and how it might present, or Graves and how it might present, and then we can talk about the blur maybe between the two.
Yeah, I mean, Hashimoto's can present itself in just classic hypothyroid symptoms. So, the classic things you think of, it could be weight gain, fatigue, constipation, dry skin, losing your hair, all the classic things you think of with any sort of hypothyroid symptoms. I also see some Hashimoto's patients, though, too. They present, one day they may be tired and fatigued. The next day they may have a little bit of racing of a heart. So sometimes it gets a little confusing where they could have a little bit of both. But typically when you're looking at a Hashimoto's patients, they're going to present classically like a really hypothyroid patient is. And if they're not specifically being tested for that component may just be, oh, well, you're just hypothyroid, take your medication and be on your way. They may never get diagnosed with Hashimoto's and know that they have an autoimmune disease. And Graves, you can go ahead and describe Graves, but yeah, that's almost like the complete flip side of it.
Yeah, so I think what we have to make sure we understand is in an allopathic model, when doctors are looking at, you're complaining of all your hypothyroid symptoms, at that point in time, your TSH may be normal, T4 normal, and your allopathic doctor would, based on their criteria that they use, if your TSH isn't elevated, your T4 is not low, then you do not have a hypothyroid condition. And they are clearly just really defining what's happening at the gland. The gland is not incapable of producing thyroid hormone. So until the gland can't produce enough thyroid hormone, which is defined by elevated TSH and T4, you don't have hypothyroidism. Now, we would argue from a different perspective. And our argument is more that, hey, hypothyroidism is really a cellular event first, because the symptoms are experienced based on what's happening at the cellular level, not what's happening necessarily at the gland. So you can have hypothyroid symptoms because you have insufficient thyroid hormone at the cell long before the gland becomes dysfunctional, because the cells control what happens to the thyroid hormone, and they determine whether thyroid hormone's activated or deactivated. And that's why in a functional medicine practice, we're going to look at more than TSH and T4. We're going to look at T3, free T4, free T3, T3 uptake, maybe thyroid binding globulin, maybe reverse T3, look at the ratios. We're going to look at the antibodies as well. And we do want to look at the antibodies even before the TSH goes out of range, because we want to see if there is early indicators of potential autoimmune attack. Now, if somebody presents with hypothyroid symptoms, we're typically running TPO, thyroglobulin antibodies, because those are the big ones associated with low thyroid function. I'm typically not running TSH antibodies or TSH receptor antibodies or TSI antibodies for somebody who's coming in and presenting with hypothyroidism. I don't know if you're running those initially, because usually if somebody's presenting as hypothyroid, we're not as worried about those antibodies, because typically thyroid receptor antibodies that we see in Graves can be inhibitory, but many times they're also they're blocking. But for the most part, we're looking at TPO and thyroglobulin antibodies. And why we want to see those early on is because we want to see if there's early indicators of damage or attack at the thyroid gland. Now, when we look at the literature, or if we talk to a medical doctor, they may say, well, those antibodies could be transient, they may not have any effect, it may never turn into a primary hypothyroidism, but we should take note, right? Because something is going on where the immune system is creating some damage or attack to the tissues. And so it is important for us to take a look at those things. And what we talked about previously, I think we talked about, is based on what the research is showing, by the time your TSH goes above range and T4 goes below range, you've had 90% loss of your thyroid function. So why would we want to wait until that time frame to act, right? And so in the medical model, the issue is, hey, it could be a transient thing. It may go away on its own, or it might progress to subclinical hypothyroidism, which is high TSH, normal T4, or it could progress to a primary hypothyroidism. But their concern is not to do anything until we go out of range, right?
Yeah, and the problem with the medical model is that unless they have those values out of range, the TSH or the T4, they're not going to be able to put you on medication until that time. And even if you had the antibodies and they diagnosed you with Hashimoto's, they don't have an option for you. There isn't a pill for Hashimoto's. So oftentimes they don't have a solution. So why would they even run the antibodies? Because they don't have a treatment for you. And to them, that it doesn't matter whether you have it or not. We're just going to keep watching your numbers. And when you get, to a certain level, then we can put you on medication. But a lot of those patients are left suffering for a very long time in that in-between range.
And so really important point that you talked about before, and that is if there's damage occurring at the thyroid gland, some patients experience both hypothyroid symptoms and they experience some symptoms of hyperthyroidism, right? Mm-hmm. Now, I recently talked to an endocrinologist and he told me that doesn't happen, but I see it clinically all the time in the practice, because when there's attack or damage at the thyroid gland, some thyroid hormone can be dumped out of the system, and that can kind of upregulate some of the systems and increase some of that hyperthyroid symptomatology, especially things like night sweats and heart and some of the palpitations and things that we see in people who are like, these are like hyperthyroid symptoms, and it can be a real thing. The endocrinologist I talked to said it doesn't happen, but we see it clinically. I just don't think what happens in their world is that they associate it because TSH is normal, T4 is normal. They associate that with something totally different, or if the person's hypothyroid, they assume that it's some other mechanism that's occurring, and it doesn't have any relationship to the Hashimoto's thyroiditis, right? And that's the thing it's another thing we probably need to talk about is what the heck is thyroiditis, right? We see that all over you have thyroiditis, you have thyroiditis. Is that hypothyroidism? Is it not hypothyroidism? For those people who have been told you have thyroiditis and you don't have hypothyroidism, thyroiditis just means the inflammation of the gland. And there's a number of different kind of types of thyroiditis, but essentially what you're getting is inflammation of the gland. And so that's what that means. And it could be caused by multiple things, but many times it's essentially what you're having is an inflammation or an autoimmune attack on the gland. And that's creating this swelling or this inflammation. That's what that means. You could have thyroiditis and not have an overt hypothyroidism. You could have thyroiditis and have more of a hyperthyroid pattern, but that's what that thyroiditis means.
Yeah. And even a lot of patients, whether they're getting the ultrasound scan of the thyroid and they'll say, oh yeah, it's enlarged or it's inflamed, the thyroiditis, they're going to call it the inflammation, but they don't ask the next question of, if there's inflammation, there's obviously something causing that inflammation. And that would be that next step to try to evaluate that. Some patients will come in and say, it's hard to swallow pills. I have a hard time with that. Or a lot of patients, you visually can see the thyroid gland being swollen, like their neck is swollen. So, and that often just gets brushed underneath the rug. If their labs are normal, they just say, there's something's causing it, but it's not a big deal. We'll just keep an eye on it. But I think that you have to then ask that next question. If the labs are normal, but yet you're still having all this inflammation, where is it coming from? It's coming from somewhere. It doesn't just poof, happen for no reason.
And I think the reason of that is in that allopathic model, there's not a game plan as to like, okay, let's go figure it out. And so what I was just told recently is the reason we just look at it as a transient event, could get worse, could get better. Many times it gets better. And it could be triggered by anything, bacteria, viruses, could be stress, could be anything. We don't know what it is, so we don't worry about it. Different in the functional medicine model, we are worried about it. We want to know what might be triggering it. And the problem is, in the allopathic model, they really like clear things. If you have E. coli, it causes diarrhea, right? We like A causes B. The problem is that many times there's 10 things that could cause a problem, and we don't know which one of those things it is. So many times the allopathic model, I think what happens is we defer to symptom management or watch and wait until it becomes the disease. And that's where functional medicine differs a bit. We want to find out, we want to say, okay, if there's 10 possibilities here, let's make sure we've checked all possibilities and addressed all 10 possibilities. It takes a little bit more work, definitely takes work on the patient's standpoint, and we're not trying to just mask the symptoms until we can actually see the disease. We want to see if we can figure out what one of those or multiples of those potential causes may be triggering the problem.
Mm-hmm.
Right?
Absolutely.
So we'll talk about Graves a little bit more here in a second, but I think we should kind of cover nodule. What does that mean, right? What's goiter? So when somebody says, hey, I have a nodule, right? That's like, when we talk about nodule, that's like the swelling of some of the tissue. You typically somebody's keeping an eye on, but there's some inflammation of the tissue. When somebody says goiter, usually what we're talking about is you have multiple nodules, okay? But it's this swelling or the enlargement of the tissue. And we can see that in anytime you have that thyroiditis going on. You can see that when there's hypothyroidism. You can even see it potentially if there's hyperthyroidism going on, but it's just enlargement of some of that thyroid tissue. But when somebody says you have nodule, you have a goiter, usually when we're talking about nodules, it's just one, right? I have one. When you're talking about a goiter, you got multiple nodules and causing the enlargement. Anything you want to add to that at all?
No, but I mean, that is a very common thing. And people just will just often just throw that out. Yeah, well, I have nodules on my thyroid. But again, it wasn't ever looked at to say why. That's not normal, to have nodules or something that's creating that. Again, there's an external source that's creating inflammation, that's creating that trigger to create that nodule. It just doesn't create on its own. So again, asking the questions, not just accepting, oh, well, I just have a nodule. No, there's something creating it, whether it's the foods you're eating, the stress, the viral, bacterial, there's something that's, again, creating that. So it's, again, asking that next question. And that's really what functional medicine is all about, is asking that next question.
Yeah. And I think we could the analogy for other parts of the body could be like IBS, right? You don't, we did a scope of your GI tract. We can't find anything, any disease. So it's just irritable, and we'll watch it and see what happens to it. Same thing with the nodule. The nodule, you got a nodule, it's there's an inflammation there, it's an enlargement there. We're just going to watch it, right? We'll see what happens. That's the medical model. The functional model is to dig in and get to it so it doesn't turn into the disease if we can help that. But knowing that there's enlargement there, something's going on, and we need to take a look at it and address it without a doubt. So then we talk about the other side of the coin is what we call hyperthyroidism, right? And so we look at hyperthyroidism as a excessive production of thyroid hormone, and primary hypothyroidism as a reduction of thyroid hormone. So typically, somebody who's hypothyroid, they're going to have elevated TSH, low T4, low T3. Free hormones are probably going to be low. When we talk about somebody who's got hyperthyroidism, we're talking about really low TSH, and they're going to have elevated levels of T4, T3, free T4, free T3, and that flooding of thyroid hormone is going to ramp up their physiology. And so they're going to have, typically, we talk about things like, we see the eyes, the pressure in the eyes. The person's going to have palpitations. They could still potentially have some hair loss depending on how long it's going on. They could have diarrhea. They could have fatigue. They could have all kinds of symptomatology of, you'd think when somebody's hypothyroid, they're tired, fatigued, and you think about the person who's hyperthyroid, you're going to think that they're going to have all this energy because they're hyperthyroid. The reality is their heart may be racing out. They may have a hard time sleeping, but a lot of these people don't have any energy because they are just wiped out by the flood of hormones into the system. And it's a scary process because pulse rates go up. Person can have their heart beating irregularly and really fast. So it really is a scary process and something that needs to be managed. In Graves' disease, or in hyperthyroidism, we have to determine, okay, what's going on when we see a hyperthyroid state. Most cases, I would say, are triggered by autoimmunity, right? And we're looking at something like a Graves issue. However, and in Graves, what's happening in a Graves situation, and the body's producing antibodies, typically against what they call the thyroid receptor antibody. So without getting too heavy into the weeds, there's antibodies that bind to the thyroid receptor, and that causes the thyroid gland to keep being stimulated to pump out excessive amounts of thyroid hormone. And so that can be, that kind of triggers the process. What causes that to happen? Again, it goes really back to the same things, a combination of genetics, stressors, and the uniqueness of how the immune system is being stimulated. So there's probably some pre-existing genetic things they're going to have an effect whether you're hyper or hypo, but the same mechanisms apply. So if you're looking at how do I fix my Hashimoto's and how does that apply to Graves, the same things could really trigger a Graves response, right? It's the same stressors, same issues going on.
Yeah, I mean, even just attack on the thyroid gland itself has the ability to destroy thyroid tissue and release those hormones into the free system, correct?
Yeah, so you can have Graves disease, you could have this hyperthyroidism caused by Graves, like the antibodies binding to the thyroid receptors, causing the thyroid gland to just nonstop pump out tons of thyroid hormone. Or you could have what we call thyrotoxicosis, and we'll call it Hashimoto's thyrotoxicosis, where we talked before that antibodies can damage the thyroid tissue, and then you can get a dump of thyroid hormone into the system, which can create the same presentation, which is a hyperthyroid state. What we typically see in practice is people probably get little floods of that, right? And they get some of that hyperthyroid symptomatology. But when you get a Hashimoto's thyrotoxicosis, it's a massive dumping out there, and it can present exactly like Graves' disease. And I think many times it may be misinterpreted as Graves' disease when it really is just part of the Hashimoto's toxicosis. Now, if you ask, like the endocrinologist I talked to said, hey, that doesn't happen. It's very rare. it doesn't happen. The reality is it does, but because we rarely ever test TPO and thyroglobulin antibodies, if somebody shows up with really low TSH and really high T4 and T3, the mindset is not just going to, hey, let's find out if it's Hashimoto's, because that's associated with hypoactivity. The thought process right away is, this is probably Graves. That's where we have to go. And to be fair, if it's an emergency situation, yeah, we're trying to get this person's pulse under control, trying to get these thyroid hormones kind of shut down, trying to get this person stable so they don't have a more severe issue go on. But we still have to take a look at the person. Do they really have Graves' disease, or do they really have a Hashimoto's toxicosis? In the moment, the treatment is probably going to be the same. Let's get the heart rate slowed down. Let's keep these thyroid. Try and get the thyroid hormone under control. Let's have it stop getting into the tissue, so it's not creating all the symptomatology. But long term, it is important, because we want to know which, at least in the functional medicine model, what is it autoimmune? Is this Hashimoto's? Is it Graves' disease? Because we're going to look at that from our model, maybe from a different perspective of how we manage it. If it's a true hyperthyroidism, like a true Graves, right? We're going to look at same thing. We got to calm it down, and we can use things like lemon balm and buggleweed and L-carnitine to help kind of calm that immune or that thyroid hormone production down, prevent it from getting into the cells, calm down the response of the thyroid hormone. But we're still going to go back to our primary things and say, hey, what is potentially triggering it? If it's Hashimoto's, we know that this is probably not a long game. This is probably a short episodic episode if it's a Hashimoto's toxicosis. And that short-term support can get those things under control. And then we know we're back to the same thing. Okay, let's figure out what this is. The concern for me, and it maybe for you, is if somebody jumps right to Graves, thinking it's Graves, they may start to then go, okay, we need to shut down the gland, whether it's thyroidectomy, whether it's radioactive iodine, and shut this baby down. And we don't want somebody to, if nobody's taking a look at all the antibodies to really see is it Graves or Hashimoto's, they may defer too quickly to getting rid of the gland. And that's what concerns me the most.
Mm-hmm. I agree with that. I see far too many people who just get their gland just taken out because they didn't really know what was wrong with it. Let's just take it out, and you'll be fine. You'll be on thyroid hormone for the rest of your life. And they think that that's the end of it. But most of those people still have thyroid symptoms, even though they don't even have a thyroid gland because it's a cellular thing.
Right. And so I think that part of the issue is if it's, if the thought process is right away that, hey, you got Graves, we're gonna try and kind of shut the gland down. And to be fair, I think what a lot of the endocrinologists will do is they'll give one of the medications, methonidazole or one of those types of medications to decrease the production, like TPO inhibitors to prevent the thyroid gland from making hormone, which makes sense in the moment. And then they'll give something like propranolol to decrease the heart rate. Now, in a crisis situation, that's probably the best thing to do, but there are some natural ways, and some of those things I kind of mentioned, the things, L-carnitine. L-carnitine can be really helpful to decrease T4 and T3 transit into the cell. So that can be helpful. The buggleweed can really help, do a really great job of bringing the pulse rate down and preventing the actions of T3 and T4. So some of those things can be really helpful, but in a crisis situation, we definitely want to get the person stable and under control. But there are other things beyond the meds that can help manage it, but you need somebody to help you do that. I don't recommend anybody just say, hey, let me see what I can do here. But I think the important thing is differentiating. And I don't think enough in the allopathic model, you're going to get much of that. We don't want somebody just saying, hey, we're going to shut down the gland, because we want to have the gland. The gland's there for a reason, and we need to identify why that attack's going on. One of the big things I think we can touch about too is, how do you determine whether you have Graves? How do you determine if you have Hashimoto's? Is what antibodies are we looking at, and what do they mean, right? So you want to talk about Hashimoto's, what antibodies we typically look at?
The big one is going to be the TPO and the thyroid.
Thyroglobulin?
Yes.
Yeah.
Those are going to be the two biggest ones that we're going to look at for Hashimoto's purposes. And I often see sometimes, yeah, most of the time they're going to be out of range, but even if they're starting to produce some of those antibodies, I've read studies that show that any amount of those antibodies, within a matter of, 5 to 10 years, you could have full blown Hashimoto's. So sometimes I even will point that out to people and say, look, you have some antibodies, we don't have anything, maybe we do or don't have anything to compare to see if they are on the rise. But I think that's an important thing to see the track, because you don't just wake up one day and have autoimmunity. You have to build that up over time. It can happen quick, but it also can just be built up over time. So looking at the track record of those antibodies, I think, is also important.
Yeah. So Hashimoto's we look at those TPO antibodies. That's thyroid peroxidase antibodies, and thyroid peroxidase is the enzyme that helps convert, kind of get the iodine binding to the thyroglobulin inside the thyroid gland and making your T4, T3. So it's really important, this peroxidase enzyme. So TPO antibodies react against that TPO enzyme, preventing some of the production of thyroid hormone. When you have TPO antibodies, that's typically more associated with damage at the gland. So we'll typically see more damage in the gland with TPO antibodies. And then there's thyroglobulin antibodies, and that is, thyroglobulin is the base from which all thyroid hormones are made. Now, we typically, when we see thyroglobulin antibodies, we typically don't associate thyroglobulin antibodies with like the autoimmune attack occurring in the gland. That's usually autoimmune attack occurring to that thyroglobulin in the bloodstream. So it doesn't mean there isn't damage there. Usually that thyroglobulin is dumping out of the thyroid gland due to some type of tissue damage. And then the thyroglobulin is hitting the bloodstream, and then the immune system is producing antibodies, what it looks like at the bloodstream level. And so why would it do that? And it seems like when the thyroglobulin hits the bloodstream, it binds with iodine, and it's the iodine takes that thyroglobulin from, because you can have thyroglobulin in the bloodstream normally. Why wouldn't the immune system normally attack it? And it's thought that when you get this big dump of thyroglobulin into the system and it binds with the iodine, it changes the structure and makes to the immune system, makes it more what we call antigenic. It makes it like maybe more foreign, like, hey, that's not the way it should look, and that triggers the response. So you can have TPO antibodies, you can have thyroglobulin antibodies in Hashimoto's, and there are some other antibodies that can occur, but we don't typically test for like Pedrin and some of those other things. TPO and thyroglobulin are the things we're going to typically see. Now, there is, in Graves, there's what they call TSI antibodies, thyroid receptor antibodies, and there's thyroid blocking antibodies and thyroid stimulating antibodies. But essentially what we're running is thyroid receptor antibodies. And we're looking for these thyroid receptor antibodies in Graves' disease. And so somebody might differentiate what's going on. If you have high levels of TSI antibodies, thyroid receptor antibodies, you probably have Graves. And if you have TPO and thyroglobulin, then you have Hashimoto's. And then we also look at what's the presentation, right? Is TSH low, T4, T3 high? It's probably Graves. If TPO or thyroglobulin high, TSH high, T4 low, then you probably have Hashimoto's, right? Autoimmunity difference of the two. There is some confusion in that, hey, if you have Graves, you only have TSI or thyroid receptor antibodies. You don't have TPO or thyroglobulin. And the reality is you can have antibodies to TPO, thyroglobulin, and thyroid receptors in Graves, and you can have all three of those antibodies in Hashimoto's as well. Those two things can be going on at the same time, but you're typically going to see higher levels. When you have Graves, you're going to see typically higher levels of those thyroid receptor antibodies, okay? When we were talking before about the Hashimoto's toxicosis and dumping those things out, that's why you and I want to see what those antibodies are, because if the TPO and thyroglobulin antibodies are higher and the TSI antibodies are low, then it's probably more likely that we're having the Hashimoto's toxicosis versus a Graves. But it's just presenting very similar to Graves because we got this hyperthyroid state going on.
Yeah.
Okay. Anything you want to add to that?
No, I think, and again, I see that presentation very frequently when patients come in that have Hashimoto's, is that they'll have, again, combination of both. And it's because they may have destruction, the dumping effect, and then they go back to being the hypo symptoms. And so they can bounce kind of back and forth. So I think it's important that even if you have the hyper symptoms, that you still look to see, is it, could the Hashimoto's be present as well?
And the definitive test should really be like a radioactive iodine uptake, and that taken a look at. So that's really the defining test. You're typically going to have to wait in most cases if you present with a hyperthyroid state, and somebody's put you on medications to shut down thyroid physiology. You're probably going to have to wait till that process comes down to do that radioactive iodine uptake test. But that's really the definitive test. And that may make a decision for somebody else in a medical model to say, hey, we got to get rid of this thing. We got to radiate it. We got to kill it. In our model, if there's crisis mode going on, you got to do what's best in the patient's interest. But if that radioactive iodine shows it's probably more of a hypothyroid Hashimoto's toxicosis, then we want to make sure that, hey, this is going to be a temporary thing. Let's get it calmed down. And then we got to get back to our roots, which is what's causing it, what's triggering it. But I think maybe if you were told you have Graves, you want to make sure that you might want to fight to find out are you sure it's Graves, or is it possibly this Hashimoto's toxicosis? And I think what medical doctors and endocrinologists may tell you it's extremely rare. I think it's not as rare as they believe. I think it's probably, but it's just not being looked at. Nobody's looking at the TPO antibodies in that side of the coin to say, hey, this is probably a Hashimoto's flare or Hashimoto's toxicosis that's going on. And make sure you understand that you can have, as I was told, you can't have TPO antibodies and thyroglobulin antibodies when you have hyperthyroidism, and you absolutely can. And you can because they're found even in a Graves situation, and you absolutely can because it may not be Graves, it may be this Hashimoto's toxicosis where you get that dump. And if nobody looked at your TPO or thyroglobulin antibodies previously, then they don't know that those things were elevated prior to the whole event occurring.
Yeah. And I think the takeaway message is that you got to be an advocate for your own health. If you're seeing these specialists and they're, maybe asking them the question, even if they say it's, very, very rare, maybe you are that rare case to them. So, being your own advocate and, looking and asking the right questions. And then if you don't feel right with the answers, then seeking out, maybe the other side of it in functional medicine and trying to get to that root cause, I think is very important.
Yeah. And so you have to be an advocate. And even whether it's, if you have this thyrotoxicosis occur and it's Graves or a hyperthyroid event, or you have Hashimoto's, or you get diagnosed with nodules, fight to try and get some more understanding from your endocrinologist as to what their thought process is. But also don't be too disappointed that you don't get a solid answer and have them say, hey, we're going to look for the cause. It's just not what's done. Once you start asking those questions like, why is this happening? You're probably going to be told, we don't know why it occurs. It just happens. It may go away. It may not. It may get worse. We're just going to watch what happens and manage your symptoms until we see if it turns into Graves, if it turns into primary hypothyroidism. We're just going to watch and wait. And I think to some degree, it's great that we're not jumping to treatment and medication, but I think somebody's got to take the bull by the horn and say, okay, let's start looking for why. And I think that's really our wheelhouse in functional medicine. So instead of saying, hey, the medical doctors are doing the wrong thing, they're actually doing what they're trained to do, treat disease. And we don't want them rushing in full guns blazing like, hey, you're hypothyroid, or you have those thyroid antibodies, let's just dump more thyroid hormone into your system and we'll try and take care of your symptoms, because that could actually make the whole process even worse. And so we don't want that. So ask the questions, try and get some of those things done, but don't be disappointed when you don't get solid answers from your medical doctor or endocrinologist, because that's just not their wheelhouse. That's where you start turning to functional medicine and say, okay, what's going on here? And the things that Erica and I talk about all the time, like, hey, there's a lot of things you can do to get this stuff under control. If you get diagnosed with Graves or Hashimoto's, there's so many things that you can do on your own to start the process. And we'll kind of run through some of those things real quick, just to finish up today's podcast. Like, we talk about improve your sleep, right? You got to protect your sleep. You got to get good 7-8 hours of sleep every night with uninterrupted sleep. Otherwise, you're going to have chronic stress, right? What are some of the other things that we can have that we tell the listeners that they can work on, that we talk about all the time, that they can do before they start trying to dump a whole bunch of supplements into the system? What can they do to reduce their stress response, to reduce their cell danger response?
I think, food, we've said it a million times, food, obviously you want to be eating a whole food type of diet, try to get rid of all the processed food, make it simple. There's we've talked about, there's tons of podcasts out there that we've talked about the autoimmune paleo and the different types of diets, but it comes down to eating real food, reducing and controlling stress in the body, whether that's emotional stress, the physical stress you're going under. You talked about the sleep, we've got the breathing. We hound this on every single podcast, but those are the foundational things. And, you can go back and listen to any of the episodes where we talk about this stuff. But I think working on those foundational things, I think is very, very important.
Yeah. And I think one of the things you got to be really careful with, and this just happened to me in the practice the other day, somebody came in with, I don't know, they're taking 14, 15 supplements, and they're trying to fix their thyroid autoimmune issue by taking more supplements, right? They were read that, hey, if I take more vitamin D, that'll lower my antibodies. If I take more selenium, that'll lower my antibodies. And they're taking all this stuff, and they're not any better. And so those things are on the blog, but I just read a paper the other day that there's been that taking more selenium has not consistently shown to reduce thyroid antibodies. Taking more vitamin D does not consistently lower antibodies. And I don't know, we've talked about this both the times. I don't know if loading your system with vitamin D is a great thing to do. Could it lower antibodies? It could, because it suppresses the Th2 side, that humoral side, but it increases the Th1 side, which is more of the inflammatory side. So I don't know if it's really the best thing unless you're looking at both 25 and 125. But please don't get caught up too much in the process of what do I do to force my antibodies down with some type of supplementation versus what can I do from a lifestyle and diet perspective to improve or correct that's naturally going to stop this danger response versus trying to fix it by adding another supplement to your regime, because that's really the allopathic model, right?
Mm-hmm. I know it certainly is. And that's the easy route. It's easier to take a pill than it is to eat better or sleep better or work on stress. So I get why people want to do it. It's the quick fix, but again, it's a lot of times that's not fixing the underlying problem. So, you want to get to those root foundational things and start working on those before you jump to just taking a million supplements.
Yeah. And it's not that we don't use supplements. We talk about trying to do those other things, and somebody called me out the other day and said, well, you use supplements. I do use supplements. I don't use a ton of them on purpose. But what I'm trying to do with those supplements is not try to fix the thyroid gland, or try to increase thyroid hormone production, like try to fix the gland. Most times I'm not doing much to try and fix the gland at all. What I'm trying to do is reduce what those stressors are, trying to fix a GI problem, trying to fix a chronic infection issue, trying to restore or reduce some of those peripheral stressors, working on those things. And many of those things don't require a supplement. For you to breathe properly, you don't need that. For you to get good sleep, we may use some supplements to support better sleep, at least temporarily, till we get the habits and behaviors better, till we get cortisol under control, till we get blood sugar regulated. But the solution isn't to just give people, and endless amounts of supplements to treat everything, because what happens is you wind up on 5, 10, 15, 20 medications or 20 supplements, and those supplements then create a problem. I just had a lady the other day who came in, she's taking about 400, or she's taking so much B vitamin, and really at this point with how much B vitamin, especially B6 that she's taking, it's probably really creating much of her nerve symptomatology that she's having. And I'm like, man, we got to get you off this stuff. But she's terrified to get off the stuff because this is the stuff that's helping me. But I'm like, if you're this sick and you're taking massive doses of supplemental B vitamins, they're probably more part of the problem than they are part of the benefit. So our mission here is to get you to do as much as possible through diet and lifestyle before you start flooding the system. Be proactive about your health. If you've got thyroid issues going on, work with the best you can with your primary care or your endocrinologist to kind of help have them rule out some of those pathologies. That's what they're really good at, looking at the pathology and kind of ruling those things out. And once they rule out that it's not it's not cancer, it's not a gross pathology, then really the best place to work is with a functional medicine practitioner to get to those root cause issues.
Yeah, I agree.
So I think we kind of beat that one up a little bit. Is there anything we didn't cover?
No, I think we did a well-rounded look at different autoimmunities that can happen with the thyroid pathways.
Okay. So if you have any questions about autoimmunity, anything we talked about in this podcast, any questions, just reach out to Dr. Erica or I, wherever you're watching the podcast, shoot to us our emails, and just ask us what your questions are. We want to hear your feedback. If we missed something, let us know. If there's something you need more answers on, let us know. You can find me. My website is www.rejuvegencenter.com. I also have the Thyroid Problems Doctor website. I have videos on YouTube, Vimeo. You can find me those places. I'm on Instagram as well, Facebook. And Dr. Erica has contacts. Where can they find you?
brainandbodyhealthcenter.com, Facebook, Instagram, YouTube. You can find us on all those platforms.
And if you're enjoying the podcast, please share it with your friends, your family, especially those that you know are struggling with some type of chronic fatigue, chronic weight gain. If you see their hair thinning, they probably have a thyroid problem, whether they got diagnosed or not. Share the podcast with them. And then if you love the podcast and you want more information, go to iTunes or wherever you watch it and give us I'd say 4 or 5 star rating. Right? All those things are helpful. But we appreciate everybody who tunes in every time we put a podcast out. We'll try and keep this train going. Dr. Eric and I will do some more kind of listener question ones coming up and talk about different things. I think one of those things we may need to talk about is thyroid hypothyroidism and blood sugar regulation, because I think that's a big thing that people are struggling with chronic weight gain and insulin resistance. And they're often told that the reason they are insulin resistant, they have body fat, is because they are eating too much and not exercising enough. And I don't think doctors are really understanding the mechanisms of cellular hypothyroidism and the implications that has on insulin resistance and prediabetes. So maybe one of our next ones we'll talk about is insulin resistance and blood sugar problems and fat gain. We can talk about iodine. We can talk about some of the other things that destroy it. But I think definitely there's a ton of more topics that Dr. Erica and I can get onto in between having some of these guests on. Okay?
Absolutely.
All right. Well, we're going to sign off. We appreciate everybody listening. Please share. Please give us some rating, and we will talk to you. And you'll hear another Thyroid Answers podcast in the next week or two.
All right. Sounds good. All right.
Okay,
bye.
everybody.